Hello guys, just wait a second. Hey guys, hope I'm audible and visible. I'm just opening the link so that I can reply to your messages. Fine. Uh, hope just opening the. Sorry. Okay, hope I'm audible and visible. If so, just say hi or something. How are you guys doing? I hope you're doing good. Fine. So, good evening, SB. So we are in one more good evening, Anil. 5 p.m. session where I'm going to discuss a little bit about arthritis, like I said in the Telegram group, right? Hello, thank you, Hannah. Good evening, Karthik. Fine. So what we're going to do here is, hi, Yashwant. So the routine things first. I'll have daily session at 5 p.m. on YouTube and daily 10 p.m. at the Unacademy app. You can see the links under my profile and Ranjith AR. Fine. So today's question, we'll go straight to the question. We'll not waste much of time. And before that, I hope you know about the compete and you are using the compete to the best of you, competing with your peers, so that you know where you stand. Good evening, Shita. Good evening, Manoj. Okay, and if you're not a subscriber, you can subscribe to the Unacademy, any of this plus or iconic. Use any code, whatever you have, or if you don't have one, use Pathocups. Fine. Okay, let's go ahead. So 5 p.m. sessions are just very short. The reason for this 5 p.m. sessions was mainly to make use to solving at least one MCQ per day so that we can make it a routine. Once you made it a routine, it's very, very easy for you, right? So to support you, I have also created a own routine for myself. So till NEET exams, I'll be posting 3 PYQs in different subjects. What I'll be doing is I'll be posting PYQs from 2014, 2015, 2016, which most of you might have not seen that, right? Okay, Nanavel, I'll look at compete. I was told it's working. I'll see if there's any trouble. I'll convey to the team so that if it is not working for everyone, definitely I'll ask the team to have a look into it. Fine. Is it working for others or is compete a problem for everyone? Okay. So if you're in the Telegram group, make it sure that you attempt all the 3 MCQs, 3 PYQs in different subjects. I'm just going to post old PYQs and I'm also in the process of collecting all the PYQs as a PDF and I'll try to give it to you before the NEET exam. Fine. Okay, so let's start with today's question. This is today's question. Read the question carefully and give your answer. Okay, Anand. Input taken. I'll just convey to the concerned authorities, teams. Okay, what could be the probable answer here? Okay, Avinash has gone with C. Nyanavel has gone with osteoarthritis. That's C again. SB has gone with C. It's a pretty decent and easy one, right? It's C. Great. I want everyone here to comment. The purpose of you commenting here is if you make a mistake, you won't repeat the same mistake in the main exam. Perfect, right? So osteophyte is a cleansing point here. So it's very, very easy for you. You can pick it as C, right? Now, when you look at it, it's a healthy 44-year-old person, increasing backache, right hip, and so and so. Radiograph finding is bony enlargement of distal interphalangeal joint. It's mostly a radiology-based question, right? Prominent osteophytes involving the vertebral bodies. So, what's the most likely cause of the disease? It's simple, like you said, it's osteoarthritis. It's not rheumatoid arthritis, not gout or osteomyelitis, right? Why I took osteoarthritis here is generally we don't look at the pathogens of arthritis. We generally look at the first few halves of systemic pathology, then we leave arthritis, bone, skin and skeletal muscle just for namesake, right? So I want to take time here and talk about your osteoarthritis also, because osteoarthritis also has an amazing pathogenesis, which I want everyone here to know it, fine? Tell me what comes to your mind when you think of a risk factor for arthritis. There are actually 2 risk factors for osteoarthritis in particular. Can any one of you tell me at least one risk factor which comes to your mind apart from age? Age being one of the predominant risk factor for any arthritis. Apart from age, do you know anything? Right, like I said, apart from age, do you know anything as a risk factor for osteoarthritis? Age is definitely a risk factor. Weight, right? Weight is a risk factor. Trauma, I would not consider it much as a risk factor for osteoarthritis, maybe for other things. Right? Weight is a very, very important risk factor. There are 2 main things which happens in osteoarthritis. One is genetic risk factor also. Genetic risk factor also is very, very important. In addition to that, your weight. Instead of calling it weight, I would call it biomechanics, right? It's not just weight. It's also the way the person walks. If a person walks like a catwalk, just for a namesake, right? If a person crisscross and walks, can I say the axis will not be perfect? Because my body has an axis. The weight always is transmitted in the tip of the, from the acetabulum to the knee joint to the ground, right? So the axis, if it is not proper, anything which alters the axis of weight transmission is a risk factor for osteoarthritis. Gait is one of the important thing and weight is one of the important thing, right? So what happens when this genetic risk factor and the weight goes and hits a joint, there is going to be initially a chondrocyte proliferation. The chondrocytes proliferates a lot initially, right? Because it's definitely it's an adaptation, right? So if there is more amount of weight, the first person to get injured in a joint is bone or articular cartilage. If there is a very heavy person or the gait is abnormal, who will be the first person who will get damaged? Articular cartilage or your bone? It will not really be an articular cartilage, right? Cartilage is the first person who's going to get damaged. So chondrocytes will get damaged. If anything in my body gets damaged, what is the response? And chondrocytes can divide. What do you think will be the initial response? It's definitely undergo a hyperplastic change, right? I'm going to damage something, the stem cells comes back, proliferates more, right? So what happens initially is the chondrocytes is going to proliferate a lot, right? There'll be increase in the number of chondrocytes. This is not a problem for me. This is very good for me. It's a response, right? It's just response. I'll have more hyperplasia and a little bit of increase in size as well, right? It'll be proliferating. So this is a very, very good response for me. So what happens is, let's say this is your joint space, a normal joint space for us. And just a second, sorry. And I'm going to have the cartilage here. The cartilage kind of increases in size. If the cartilage increases in size, it becomes bigger. Can I say the joint space will become wider? The cartilage is just proliferating in response to this. Yes, the joint space definitely becomes wider, right? So this cartilage proliferation over the period of time, whenever the damage becomes more and more and more, it cannot sustain, right? So if the weight is not being reduced or the genetic influence is more, it cannot sustain that. So what happens is, over the period of time, this cartilage starts destroying, right? There'll be a reduction in the cartilaginous or the collagen destruction. So when the collagen reduces, collagen in an articular cartilage are oriented like this, horizontally. This is how the collagen is oriented in articular cartilage, any articular cartilage, right? So let's assume this is joint space and these are the articular cartilage and the collagen what I'm drawing here. There's a destruction of the collagen, fine. I hope you are doing good as well as Ian. I hope your PG life is also good, right? So when this destruction happens, this destruction will result in breaking down of the articular cartilage. The articular cartilage, it becomes like this. It's just broken because of the destruction of the horizontal collagen fibers. It gets broken. So then, is there a possibility that this articular cartilage can be cut off from the original thing? There's a tiny projection. Can it get cut off and go into the joint space? Again, for understanding, this is a joint space. This is a joint space. Is it possible? It's definitely possible, right? This can get cut off and goes into a joint space. So once this gets cuts off and goes into the joint space, I'm going to have cartilages or the pieces of collagen into the joint space. What do I call this? I'm having a normal bone here, just for understanding. I'm having piece of cartilage into the joint space. What do I call this? I'm sure you know that this is one of an important MCQ. This is seen classically in osteoarthritis. This cartilage will become like a, these are not osteophyte. Osteophyte is bone, right? So these are projected cartilage are broken down and gone into the joint space. They'll be roaming inside the joint space. These are not osteophytes. Can I call them loose bodies? Yes, so these are all loose bodies, right? So loose bodies are nothing but the broken type 2 collagen or the broken cartilage which is getting destroyed, right? So these are loose bodies which will be there inside the osteocyte, right? Inside the joint space. Once the loose bodies happen or once there's a breaking, am I right in saying that the bone will get exposed? Let's assume this was the normal joint space and this part, my entire cartilage is gone. And just for understanding, this part, there's cartilage still present here, right? This part, my cartilage is gone. If the cartilage is gone in this place, will the subchondral bone get exposed? It'll definitely get exposed, right? If the subchondral bone get exposed and its joint, it's keep on moving, the person is not going to stop walking. Even with pain, the person will try to walk and move the joint, right? So there'll be friction. This friction will kind of breach the cortex. Once it breaches the cortex, this part will be tinily breached. And what's there in the space? What's there in the joint space? In any joint, I have only one person. Who is that? Can I call them a synovial fluid? Yes. So I do have synovial fluid in the joint space. So this break in the cartilage will let the synovial fluid go inside. When the synovial fluid goes into the bone, in the cortical area of the bone, when I take a X-ray of it, synovial fluid will be transparent or translucent or opaque. It's a synovial fluid. Will it be transparent, translucent or opaque? It kind of becomes like this. It'll become like an, see, it's a fluid, right? The fluid will look like a cystic cavity. It's a cyst. So have you heard about in your X-ray of osteoarthritis, subcortical cysts? You must have definitely heard about it, right? So subcortical cysts are nothing but the synovial fluid has gone into the bone and forming like a cavity like thing because of constant friction. So can I say when I reach the subcortical cyst, the damage is already done? It's already done, right? So damage is already taken care of, right? So I don't want to come in this place because subcortical cyst, if it is there, my damage is already done. Osteoarthritis, it's good amount of damage done. If you remember orthopedics and over the years of transition of management of osteoarthritis, MRI plays a very, very important role. What MRI does is, MRI can take care of this place. Whenever there's a destruction, the destruction meaning here, the proteoglycans becomes less and the water becomes more. That's what destroys the cartilage, right? So in this area itself, MRI can pick it up. The reason why MRI is very, very important in osteoarthritis is it will tell the stage of osteoarthritis, whether it's in this place. And of late, there's lots of improvement in the management of osteoarthritis also. If it's a destruction of cartilage, is there a possibility, a slight possibility, if I give a stem cell, the cartilage can regrow? Is that right? If I can pick it up an MRI, that there is a cartilage destruction happening, the proliferation is reducing. If I give or if I infuse stem cells here, will it regrow? It will regrow. Stem cells are being extremely used these days in the management of osteoarthritis if I pick them up early. But if it comes to this area, a subcortical cyst, will stem cell be useful there? It's completely gone, right? It's completely eroded. I might not expect that amount of response due to stem cell therapy if it comes to the end stage, right? So early diagnosis is always good, not for cancers alone. For any disease, for me, early diagnosis is important. When I diagnose early, I can prevent something, right? So after subcortical cyst, let's assume the entire cartilage is eroded. The bone keeps on rubbing. The bone is also having a trauma. Will the bone grow back? Bone is also a tissue in my body. Will bone have hyperplasia and hypertrophy? A cellular adaptation? Bone will definitely have that, right? So bone also has a cellular adaptation. So when bone has a cellular adaptation, that results in your osteophyte formation, right? So bone adapts and the bone outgrowth, you must have, we saw in the question as well. And that's one of the important thing for me. It's an osteophyte. So osteophyte formation is like the terminal stage. I don't want to diagnose osteoarthritis when there's an osteophyte formation. That's completely gone for me. It's destroyed and the bone is responding. I should diagnose at this stage where the cartilaginous water level and the proteoglycan level changes. So I want MRI, right? So if you suspect osteoarthritis, if you're going to be an orthopedician or even a general practitioner, because osteoarthritis knee pain comes to everyone, any MBBS doctor, right? I want you to ask them to do an MRI and refer to an orthopedician so that if it is an early stage, I can prevent the damage. Treating the damage is not important for me. Treating the damage, anyone can treat it. I want to prevent the damage so that it doesn't go into bone destruction and requiring your knee transplantation. That's not required at all. If it comes to that level, my healthcare is not good. I need to diagnose them early and I have to treat them early, right? I'll show you an image. This is from Robbins. It's a very beautiful image. This is a gross finding of an osteoarthritis. What is this? What is the structure? Whatever I'm drawing, what is the structure? The white structure. Can I call it articular cartilage? It looks like cartilage, right? It's an articular cartilage. Perfect. So this for me here is bone, right? You can see the porosities of the bone and this is your articular cartilage. If you look at this part, wherever it's marked as 1, can I say there's no articular cartilage? In this part I have articular cartilage. Maybe here a little bit of articular cartilage is seen, but rest of the bone, it doesn't have any articular cartilage, right? That it's where it's been completely destroyed. So after destruction, at this part, can I say the synovial fluid is kind of dripping inside? It's not porous here, right? It's kind of uniform here. It's looking like a liquid or a mucin-like deposit, right? So this is your subcortical cyst. You can see the subcortical cyst here. You can appreciate it perfectly. You are having two subcortical cysts. This again is your normal bony trabeculae. You can see the porosities of a normal bony trabeculae and a perfect normal articular cartilage. This is what happens in osteoarthritis. I want to prevent this. So do an MRI. If you're going to be in orthopedic, you'll know perfectly how to manage it, but it should be done very early. When the person first comes itself, I want to do an MRI, stage them, then treat them. Giving analgesics will definitely reduce the pain, will not reduce destruction. Osteoarthritis is a degenerative disorder or an inflammatory disorder. Osteoarthritis, degenerative or inflammatory disorder? It's a very simple question. It's a very basic questions. Basics are sometimes it's very, very difficult for us. Then degenerative disorder, perfect, right? So it's an age-related thing, right? So the only way to avoid degeneration is regeneration. So when I have a problem, I have to counteract the problem. The only way to regenerate is push in stem cells if required, right? That's how I reverse the pathogenesis. Other things, whatever you read in the treatment aspect, I'm going to take care of the symptom. Symptomatic approach is not the best way to treat any disease. I have to reverse the pathogenesis, right? See, should be Jain, right? Okay, see, pain in osteoarthritis is multifactorial. One, when the cartilages start destroying, it produces prostaglandins. The destruction of the cartilage, the proliferation of cartilage produces prostaglandins. Prostaglandins as such can produce pain. That's one. Second, when the cartilage gets destroyed, I have a bone which is getting in contact with the opposites, your articular cartilage. Bone should never be getting exposed. If the bone is getting exposed, I'll definitely have a problem. Loose body is not the reason for pain. The movement, the crepitus, the sound may be due to the loose body formation, but pain is due to destruction of the cartilage and the prostaglandin, which is seen as a result of chondrocyte proliferation, right? Those are the two causes of pain, right? So this is what happens in osteoarthritis. This is an image from Robbins. Remember this image. You know everything about the pathogenesis. I have a normal cartilage. It's getting destroyed. Age being one of the important factor. Weight being another important factor. There are a few genetic mutations as well, which can predispose to early onset osteoarthritis, right? And definitely has a subcortical cyst. And over the period of time, if I leave it, you can have a tiny outgrowth of bone, which are osteophytes, right? Okay, that's about osteoarthritis. Just maybe one more question. Read this question and try to give an answer. Maybe we'll discuss it a little bit and then we'll go to the next one. It's a very simple one, right? The answer is in the first line, if you carefully observe it. Great. I want everyone here to comment. It's a very, very simple question. Good. So 58-year-old person, sudden onset of severe pain in the left grade 2. Actually, this itself is enough for me to come to a diagnosis, right? Your first metatarsophalangeal joint pain in any age group, the first possibility for me is gouty arthritis. No history of trauma. There's edema, erythema, pain on movement of the first metatarsophalangeal joint, no skin ulceration, nothing is there. Joint aspirate found numerous neutrophils and needle-shaped crystals. The sodium urate crystals will have the needle-shaped appearance. Over the next 3 weeks, he has 2 more similar episodes. On physical examination, there is a minimal loss of joint mobility, fine. And the most likely finding seen in this person is hyperuricemia. The classical case of gouty arthritis, right? The only reason why I wanted to put gouty arthritis in question is, if you remember, if you see any patient of gouty arthritis in future, or if you read about gouty arthritis, what's the first etiology which comes to your mind? It's gouty arthritis. What's the first etiology which pops into your head? Anyone? What's the first etiology which will come into your mind when you think of an gout? At least some of us will think of cancer, right? I don't want you to think of cancer. Alcohol, meat, amazing thought process, right? So cancer-related gouty arthritis are extremely rare. Forget it. It's less than 1%. Diet-related gouty arthritis is definitely one of the important causes. It's a metabolic problem. And close to 90% of the gouty arthritis are idiopathic and genetic. Remember that, right? Close to 90% of them are idiopathic. Alcohol, meat consumption will trigger gouty arthritis in a person who is predisposed to gouty arthritis genetically, right? One of the syndromes which you might remember Gouty arthritis with self-mutilation and problems in your neurological thing. What disease it is? There's one inherited syndrome. I'm sure you know that. Gouty arthritis with self-mutilation and others. Leishman syndrome, right? That's one known syndrome. Apart from Leishman syndrome, I have thousands of syndromes, thousands of mutations which are unnamed, right? So if you remember, see gouty arthritis in any age person, first think it should be familial. Ask for familial history, there'll definitely be a familial history. I suffer from gouty arthritis. I have a familial history of gouty arthritis, right? It's very, very common. We just don't think that it's due to genetics. We don't realize, we don't investigate on that front, that's all. Predominant of them are idiopathic, and most of them, if you take genetic analysis, we will find a mutation for sure, right? So first is predominantly familial, and genetic is the important cause of gouty arthritis. Apart from that, like you guys said, alcohol, meat consumption will trigger, protein diet will trigger the gouty arthritis. The least important thing for you is your tumors and tumor lysis syndrome is very, very rare. It's less than 1%, right? So this is classical needle shaped crystals. What microscopy is this seen on? What is microscopy? What microscopy is this? It's seen only in your polarizing microscopy, right? It's seen only in polarizing microscopy. Okay, fluorescent polarizing microscopy. I cannot see a needle shaped crystals in a normal microscopy. I need a polarizer. Polarizer is nothing but it reflects light. It's just a normal 3D glass, that's all. It's a polarizer. It reflects light. So needle shaped crystal goes and hits, the light hits there, reflects, gives an appearance, that's all. Gouty arthritis has something called a negative birefringence. Needle shaped crystals, negative birefringence is such of gouty arthritis, fine. Okay, so the negatively birefringent crystal, what does negative mean is, if you have a polarizer, I rotate them clockwise, it gives a color, that I call it positive birefringence. I rotate the polarizer anti-clockwise and it gives color, I call them negative birefringent. That's all. That's what positive and negative means. Though it's not required for an exam, I'm just telling you so that you'll understand what does the birefringence mean, that's all, right? So next time you go to 3D movie, take out the glass like this and rotate it like this, right? If you rotate on both the directions, you'll have different colors. That's what is clockwise and anti-clockwise rotation giving colors. That is called as a negative birefringence, right? So what happens in gouty arthritis is these needle-shaped crystals are foreign body. Anything foreign in any place, who will come and try to eat it? WBCs. This since is an acute problem, which WBC comes and tries to eat it? Neutrophil, right? So obviously neutrophil will come and try to eat it, engulf it. They are very sharp. Can a neutrophil engulf it? They cannot. So the very sharp nature of the gouty arthritis will poke the neutrophil's membrane, will definitely destroy the plasma membrane. If a neutrophil's plasma membrane is destroyed, will it release the granule contents outside? Right? Definitely the neutrophil's plasma membrane is destroyed, the granule contents comes outside. Once the granule contents comes outside, will it cause inflammation and attract more and more neutrophils? It will degranulate, it will attract more and more neutrophils. When more and more neutrophils comes inside, obviously it's going to cause an acute, very severe acute inflammation. That's the reason for gouty arthritis. If alone my neutrophils was quiet, don't engulf these crystals, I won't have any problem. So primary problem here is my hyperuricemia. I have to take care of that with uricosuric drugs. The later problem, acute gout problem, is my WBC. So in acute gout, will your uricosuric drugs help? Will uricosuric drugs help in acute gouty arthritis? In an acute gouty arthritis? Just a practical point of view. Acute gouty arthritis, uricosuric drugs don't help at all, right? The only person who can help is NSAID. Colchicine is true, like Anil said. I'll tell the utility of colchicine soon. In acute gouty arthritis, I have to take care of this WBC. So I will use NSAID. The best NSAID, I can use any NSAID, right? Indomethacin is the best NSAID that will work very beautifully. Since I'm a patient, I know which drug works well. Colchicine doesn't work much. Colchicine, though it's theoretically very, very powerful, in real life, at least for me, colchicine has never worked. Indomethacin works very beautifully. If not, the last resort for me is going to be steroids. Steroids will reduce inflammation. The only reason here is I have to reduce WBC. Colchicine is a mitotic spindle inhibitor. So it inhibits the proliferation of WBCs. That's how colchicine acts. But for me here, my concern is not what happens in the bone marrow. That's what collagen does. It reduces the division of cells. For me, the problem is in the joints. I already have good amount of WBCs in my circulation. I'll go to the joints and cause all the damage and acute inflammation. NSAID works well. If not, I'm going to go for steroids, fine. So that's a problem in acute gouty arthritis. I'll go back once again here. Steroids will work for sure, right? The person has 2 episodes in the next 3 weeks, right? I'm not going to talk much about it. Maybe I'll give this to you as a homework. If you have Harrison with you, go to hyperuricemia or gout chapter, and I want you to read and comment in the Telegram group what are the indications of uricosuric drugs or your rasburicase or anything, anti-uric acid drugs. When will you give in a patient of gout? There are few classical indications. You have to give them anti-uricosuric drugs or uric acid inhibitors, oxidase inhibitors, so that the attacks doesn't come recurrently, because repetitive attacks will cause problem in the joints and also will cause problem in the kidney, right? So this is a homework. You're going to find and tell me what time or when, in which patients you will start prescribing these drugs. Some of them just NSAID is more than enough, right? Okay, we'll end with that. And one more question as well. There's one thing called a pseudogout. What will you see in pseudogout? What is the shape of crystals in pseudogout? That we can comment here itself. The shape of crystals in pseudogout. You must have heard it. That they are calcium pyrophosphate dehydrogenase and a rhomboid shaped crystal, right? Perfect. They are CPPD, and that's a positive birefringent crystal. Calcium pyrophosphate dihydrate crystals, which are rhomboid in shape and they are positively birefringent. Fine, great. So we discussed about osteoarthritis more and a little bit about gouty arthritis. I think we'll come to the end of today's discussion. See you by tomorrow 5 p.m. And if you have any queries, you can contact me in any of this platform, and hopefully we'll learn consistently together more. Fine. If you have any doubts regarding today's class, do let me know. If not, we'll call it a day. And don't forget your homework. You are going to tell me, read from Harrison and tell me when will you prescribe uricosuric drugs in patients. Right? Thanks a lot. Thank you. See you by 10 p.m. In 10 p.m. what we will be doing in Unacademy Appers, we will be taking care of apoptosis, other forms of cell death, and also a little bit about your intracellular accumulation. Fine. Yes, today we have 10 p.m. class. We'll see at 10 p.m. Don't worry. Yes, Swati, and yes, SB. Okay. Fine. Thank you. Bye-bye. Yes, ibuprofen will work, Anjana. Any NSAIDs will work. Okay. Thank you. Bye-bye.